due to the skin attenuation. Then I moved to Gothenburg for an amazing new job opportunity. And as I still needed recurrent cleaning of my ear canal every 3 to 6 months and treat some sporadic infections, I started the referral pathway again to go through primary care, an ENT specialist, and waiting lists, an audiologist, now in a new healthcare system. And in the last 5 years, I realized that my hearing has deteriorated even further, and understanding conversations in noisy environments, for example, operating rooms with the people wearing face masks, is very, very difficult, even with a 55 dB fitting range sound processor that now I use. Today, I still have some mild symptoms of chronic otitis media, and I suspect that there is still some residual cholesteatoma. And my hearing noise is challenging, and I also noticed that random tinnitus started a couple of years ago, so I'm concerned about it. But together and along with my clinical team, we're taking the next steps in the treatment by explanting the passive transcutaneous magnet to have much better visibility during an MRI, to evaluate and find out if there is still a possible residual cholesteatoma and decide on the next steps. And in the meantime, I am using non-surgical bone conduction devices like the one I'm wearing today, and it helps me very well. I know that eventually I will get an active transcutaneous bone conduction implant, and I am really excited to what it will mean for my hearing in the future, because I am convinced that it will help me to live a full life and continue connecting with others as my journey goes on. And to finish, I want to take this opportunity to acknowledge and thank all the healthcare professionals who have treated me along these years and helped me during many cities and many countries around the world. So, gracias, thank you, merci, and tack. And I will be glad to answer any questions you may have at the Q&A section at the end of this webinar.
Thank you so much for sharing your personal journey, Ivan. That was very inspiring, and for sharing also, not only your hearing loss, but all the journey throughout your personal life, the different challenges as you went through. Thank you for sharing that with everybody. If anyone has any questions, please put it in the Q&A section, and we will go through everything at the end. Thank you again, Ivan. Next up, we have Dr. Hilary Snap, who will be presenting on the importance of proactive hearing management through non-surgical bone conduction devices, very much similar to the device that Ivan is wearing currently. Take it away, Dr. Snap.
Hi, everyone. It's such a pleasure to be here with you today. I'm an audiologist and the chief of audiology at the University of Miami, and I've actually been working with bone conduction devices and bone conduction device recipients for nearly 20 years now. So it's really an honor to have the opportunity to discuss with you the work that we've been doing as part of the Healthy Hearing Ears initiative. And as we've just heard from Ivan, the journey through chronic otitis media can be very long and complex. It really is often dominated by cycles of surgical intervention and reintervention. And the lived experiences of Ivan really highlights a critical gap, right? It's not the lack of effort to control disease, but a delay in addressing hearing loss in a meaningful way. Chronic otitis media, particularly refractory chronic otitis media, is characterized by recurrent or persistent middle ear disease despite medical management, which often results in significant conductive hearing loss. Although surgery remains the cornerstone of management for advanced disease, auditory outcomes are frequently incomplete, meaning leaving residual hearing loss. In fact, approximately 30% of patients demonstrate a residual airbone gap that's greater than 20 dB, even after surgical intervention, leaving many with ongoing functional hearing impairment. And so I wanted to start here with a case example. This child presented at age 9 with long-standing middle ear disorder and a history of multiple surgeries, the first at just 11 months of age. And on the initial audiogram that you see here, there's a maximum conductive hearing loss in the right ear with a very large air bone gap. Now, following surgery, there is some improvement. We can see here about a 20 dB reduction, but most importantly, there is a significant residual air bone gap of about 40 decibels, which remains. The threshold is still about 25 dB above normal, leaving persistent mild to moderate hearing loss. Now, in fact, this was the most successful of 5 surgeries in terms of hearing outcomes. None of the procedures, as you can see here, resulted in meaningful, sustained hearing improvement. And it wasn't until the 5th and most recent surgery that the hearing intervention was introduced in parallel with a bone conduction device. And even then, the surgery itself did not resolve the hearing loss. So similar to our prior patient, to Yvonne, we see there's 5 surgeries over actually 3.5 years before the hearing intervention actually occurs. And more broadly, this reflects another major issue, care silos. Now, I know, there's often an understandable reticence to move directly into an implantable solution like this patient eventually got here. And this comes from providers, but patients as well, especially during these periods of unclear active or uncertain disease. But that hesitation creates an opportunity to initiate hearing care earlier using non-surgical options like we just saw. This allows the patient to experience the benefit of improved hearing immediately while building familiarity and confidence with the technology. So this really is the gap that we need to address, because in fact, it wasn't 3.5 years. This child, again, started with their disease presentation and first surgery at less than a year of an age, which reflects a total of 12 years before actual hearing intervention. Now, the surgical burden of chronic otitis media is significant, right? Patients with COM undergo repeated surgical interventions over their lifetime, and while some will achieve a stable dry ear after a primary procedure, approximately 44 to 55% of those with more complex or persistent disease will require at least one revision surgery. And for certain populations, particularly those with cholesteatoma, for example, multiple revisions are actually common. The literature is suggesting 3 to 4 revisions over their lifetime, but as we've seen with our patient and with our Yvonne, even more than 4 surgeries can occur. So for many, this is not about a single intervention, which is what I hope you recognize today. It's really a longitudinal surgical journey. And the consequences of chronic otitis media extend far beyond the ear. In children, the impact comes during critical developmental windows with increased risk for speech, language, and broader developmental delays. In our adults, it manifests as communication difficulties, reduced social participation, and even occupational limitations. And for families, this often means prolonged uncertainty, repeated interventions, and a diminished overall quality of life. So this is not just about the ear disease. It really broadly impacts our patients. Hearing intervention, unfortunately, or rehabilitation, is often delayed until the middle ear is considered stable, typically 12 to 24 months after the primary surgery. And during that time, patients will undergo an average of 1.7 to 3 procedures. As a result, hearing outcomes are frequently deprioritized while active disease management takes the precedence. And so this is where we're really trying to work together at the Healthy Hearing Ears Initiative is to address this gap. We've been working on an international guideline statement, and our first recommendation is this. In patients with chronic otitis media, proactive management of hearing loss with non-surgical bone conduction devices is really essential. This approach supports speech, language, and developmental outcomes in children. It improves communication, social participation, and occupational functioning in our adults. And it's really the use of the non-surgical devices that's critical during these periods of active or unstable disease, as I mentioned before, where the hearing levels may fluctuate. Again, it's understandable that there's reticence to move to a surgical solution in those early stages, but we can take a proactive step by utilizing something that's non-invasive in those early phases. Conventional hearing aids require an ear mold that will occlude the ear, potentially trapping moisture and bacteria, which can exacerbate chronic OME. In contrast, the bone conduction device actually bypasses that ear canal entirely, helping to maintain that really important dry ear environment, reducing infection and discharge in up to 84% of patients. And importantly, in patients with an ear bone gap that's greater than 30 dB, outcomes with the bone conduction devices have actually been shown to be as good or better than traditional air conduction hearing aids. So this is really about rethinking that care pathway, right? Traditionally, the care pathway for chronic otitis media is dominated by multiple medical and surgical touch points, with hearing intervention introduced, as you can see here, late, if at all. And so what we're proposing at HHE is really a shift in that timeline. From the point of diagnosis, we begin the conversation, educating parents, educating patients, educating families about bone conduction devices as a viable hearing solution. And it's this early engagement which builds understanding, it sets expectations, and it improves overall acceptance over time. And so what I'd like to propose to you is that by introducing non-surgical hearing intervention up front, we can move hearing care earlier in the disease course, rather than waiting for surgical resolution that may never, as we've seen, fully restore their hearing. We can move early with these non-surgical devices. And so if surgery does not provide ultimately a durable hearing outcome, patients are already prepared to transition to a longer-term or implantable solution. And so this approach really helps to break down those care silos. It helps us align management strategies. And most importantly, I think it really gets patients into effective hearing treatment as soon as chronic OME is identified. So this is really about shifting that paradigm, which Dr. Zawawi is going to talk about here in a second, shifting it early towards proactive intervention. And so first, instead of waiting for that surgical finality, we really want to introduce the non-surgical hearing solution, particularly BCDs, early and consistently between those surgical stages. For patients who are awaiting surgery or undergoing multiple revisions, a non-surgical bone conduction device, I hope you see, really provides an opportunity for reliable, continuous hearing throughout what is often a multi-year disease course. And importantly and lastly, there is an advantage to using bone conduction devices to manage these patients. In ears that are chronically draining or unstable, these devices, again, bypass that middle ear entirely, and therefore can be used when the ear is not dry, allowing us to treat hearing without waiting for a perfect surgical condition. And so ultimately, this is a patient-centered approach that keeps patients hearing, engaged, and functioning throughout their entire journey. And with that, I thank you, and I too am happy to take your questions during the Q&A session later. Annie?
Thank you, Dr. Snap. That was great. Next up, we have Dr. Zawawi, who will share his experience and the importance of treating hearing loss and the infection simultaneously. Dr. Zawawi, if I will get you to turn on your camera and take it away.
Hi, everyone, and thank you for Healthy Hearing Ears and Cochlear for helping us out and trying to spread the word and increase the knowledge towards managing hearing loss in patients with chronic ear disease. I hope my voice and screen is projecting well. Having trouble moving my slides.
I can help change slides for you, Dr. Zawawi.
Perfect. We can go to the next one.
Yep.
So this is my only disclosure that I'm part of the Healthy Hearing Ears initiative as a part of the steering committee, which is really an initiative of a group of experts from all around the world trying to better the hearing for patients with chronic ear disease. Can you go next, please? So this is basically a classic example. A patient shows up to the clinic, regardless of their age, they suffer from chronic ear discharge, and they've probably seen multiple experts before, or you're the first expert that is exposed to these patients, and they show up to you with whether with one ear or bilateral ear disease. And you examine them, whether you suspect cholesteatoma or not, this patient is labeled as chronic ear disease patient. You get a CT scan, you confirm a cholesteatoma, and you decide to say, okay, I need to manage this patient clinically. Next slide, please. Part of your assessment, you perform a hearing test. And for example, this patient who had bilateral chronic ear disease and cholesteatomas have had bilateral, mostly conductive hearing loss on both sides. And as you can see, this patient is significantly impacted. His social life is quite impacted. He was a 17-year-old who has had this disease for a few years now. So even at school, he had an impact on his school performance. Next, please. So from our point of view, and from the classic teaching point of view, is that you have to treat the ear first. So chronic ear disease means you have to perform and get a clean ear before you move on to hearing. And we've always spoken to patients and we reassure them, because many of those actually show up complaining about their hearing. And we tell them, listen, you have a cholesteatoma or you have a chronic ear disease, we have to fix that first. And then we move on to hearing. And that's a big issue, because sometimes that's really the reason the patient is here. And also, if it's not the real reason the patient is here, that is also a co-problem that needs to be addressed, because otherwise, as in Dr. Snap's presentation has seen, patients go throughout almost 12 years or more without getting their hearing addressed. And the hearing is impacted in many things for patients, especially for children with their speech and language development or schooling performance, or for adults, they might impact the work or college, or even elderly, they can cause them dementia and what have you. So hearing is very important. Next, please. Next. Yeah. So we like to do our fancy surgeries, and we get their surgery performed, and we either perform a resicular chain reconstruction or not. We get their hearing better, but not optimum. And then we ask ourselves, is this good enough or not? Next. So when we applied and wanted to understand what does living with hearing loss mean, or living post management of cholesteatoma means, we performed we gave our patients the hearing and the hearing handicap index, and the Arabic version of it, and we wanted to see the impact of not having proper hearing in their lives. And as you can see in the hearing handicap index, anything that is more than 16% means that the patient has some sort of a hearing handicap. And if it's more than 44, they have a significant hearing handicap. And those who did not have OCR had a significant hearing handicap, and those who had OCR had a mild to moderate hearing handicap. And then this tells you the magnitude of the problem. And even those that had some sort of middle ear reconstruction, they still had a problem. And this should not be avoided, should not be ignored. Next, please. Which means that the current classic clinical pathway is not good, and we have to move on to a better pathway. Next, please. Next. So this is our proposal. We want to propose and see if there is a way to treat both the hearing and perform the clean ear at the same time. And to do so, we have to develop a new pathway that really is effective. In our institution, this is what we adopted. Next, please. So this is our approach. The approach relies exclusively on ENT and audiologists working hand in hand to better hearing for patients. So in this approach, the patient shows up to the clinic for chronic ear disease or hearing loss. If we discover that has a chronic ear disease, he gets a hearing assessment right away. Then the second step, we discuss the surgical option for this patient, or the medical if there is some acute infection on top of this chronic issue. But at the same time, we introduce the idea of hearing rehabilitation. And for those patients, we don't really focus on conventional hearing aids, because we know they're going to go through surgeries, or if they have a chronic discharging ear, we have to get them, as Dr. Snap mentioned, to a hearing solution that will provide hearing without occluding the ear and causes or aggravating the problem they already have. So these patients end up getting their assessment for bone conduction, non-surgical bone conduction early on. And afterwards, they go for surgery. And whether they got an OCR or not, then after surgery, they end up receiving their non-surgical solution, bone conduction, and the connectized media surveillance starts. Next, please. So if we look at our cohort, for example, that went through this process, and we wanted to dissect and see, are we doing good with the new approach or not? So we divided the patients that we've had into 4 groups. Ones that had connectized media without any intervention, any hearing intervention, no OCRs or bone conduction, those who've had OCR, and the group that had an early surgical non-surgical bone conduction solution, and those that have progressed to piezoelectric bone conduction implant. Next. So let's look at the auditory outcome. If we compare those that had the primary surgery but did not have any reconstruction with those that had the primary surgery and had a non-surgical bone conduction, you can see that those with non-surgical bone conduction have a better hearing in their audiogram. They've managed to get near normal thresholds in the important frequencies that we're talking about. Next. Even though those that had OCR who generally say, oh, I feel better, they're not as good as those with non-surgical bone conduction solution. Next. And especially when you compare them to those with piezoelectric bone conduction implants, you can see that those who have had a bone conduction implant have had almost near normal bone conduction and bone hearing, which gives them normal hearing, and that's even much more superior than those who have OCR. And it's important to note that those who have OCR or those who've received some sort of conventional hearing aid have what we call fluctuating access to hearing, because if they have wax, if they have discharge, if they have inflammation in their ear, or if they have middle ear effusion, they end up getting a diminution in their hearing, which means that their hearing won't be that as optimum, meaning compared to those who have bone conduction, those who have bone conduction, whether surgical or non-surgical, will have a consistent hearing throughout their journey. Next. So what does this mean for the patients? So we've asked the patients about how does that make them feel if they've received the access to hearing and those who did not receive access to bone conduction hearing. Those who went through the classic pathway, who've gone through multiple surgeries and multiple medical therapies before introducing, getting or receiving any sort of hearing amplification or hearing restoration, feel isolated. Those that have had multiple surgeries also feel anxious. And those that are waiting for their OCR surgery say they're waiting, they can't wait to get their second stage surgery where hopefully there is no cholesteatoma and they can get their OCR done. And that tells you that they're really impacted emotionally. Where compare that to those that had early access to bone conduction, most of them have reported they're happy with their decision to move on with bone conduction. And they feel that the process was effortless. They finish the surgery because most of the time those patients have a pack in their ear, which means that they won't be able to get anything like a conventional hearing aid, or even if they end up getting an OCR, they don't know how well their hearing is because of a hearing pack. And sometimes that pack, if it's a dissolvable pack, may linger there for a few weeks. And they don't feel that they get that downtime where they lost their hearing for 6 to 8 weeks, or for example, 6 months, and they need another surgery for OCR. So that's very important for us to know, because this is, for us clinicians, sometimes we feel that we're doing this and the patient can wait until the next surgery, and we feel better when they get the better after the next surgery. But the patient ends up waiting for 6 to 9 months without their appropriate hearing. So that's something that will impact their quality of life and also their clinical life. Next. And we've looked before at the hearing handicap index for those who did not have any bone conduction, where when you look at the other two bars, where it shows you that those that had either non-surgical bone conduction or piezoelectric bone conduction, you can see that they hardly had any sort of hearing handicap based on the hearing handicap index, which is reflected by the previously mentioned in the slides, where they have patients feel that they are able to connect better, they're happy, and they feel that they don't have a downtime in their hearing. Can we go to the last slide, please? And finally, our take-home message is that we have to also focus, that we have to very importantly focus that safe ear alone is not enough. Patients come in with hearing issues that needs to be restored. So it's very important for the patient to get that hearing rehabilitation started early, because their quality of life is impacted, their daily life is impacted, and we really need to keep that in mind. The bone conduction is a powerful tool, and having the patient have access to it early is very important for their progress in their disease. And for that reason, our proposal is to have a parallel care for both for the cleaning, the healthy ear cleaning, and also the healthy hearing care. Thank you very much, and I will take the questions in the Q&As.
Thank you. That was fantastic, Dr. Zawawi. Thank you for sharing the importance of treating in parallel and that how to manage hearing in an interdisciplinary team. Thank you again, Dr. Zawawi. Next up, we have our final speaker, Dr. Mirtha Hall, who will share with us the holistic patient care management in chronic otitis media. Dr. Hall, if I can get you to turn on your camera and take control of the PowerPoint slides.
Thank you for this kind introduction, Annie. My name is indeed Mirtha Hol, and I work as a professor and ENT surgeon otologist in the Netherlands. I started working in this interesting field of bone conduction hearing already almost 25 years ago, and I'm really happy and grateful for the Healthy Hearing Ears initiative to create more awareness for patients with COM. So do we really know if our patients can hear after COM or COM revision surgery? And then you can ask yourself, what is the issue? We measure our patients most of the time. So yeah, we do know that they are hearing better. That's what we get back from them as well. But if we look into what also my colleagues have been telling to you, and I think repeating the message is the most important thing to keep it in your minds, is indeed, like Dr. Zawawi also mentioned, we have been trained traditionally to address the COM, especially the cholesteatoma, and create a safe, dry, or clean ear. And of course, hearing restoration is an important aspect of that surgery as well. Still, if we look into the literature, around 65% of the operated patients continue to have an air-bone gap of 25 to 30 decibels after, for instance, a combined approach tympanoplasty with or without the bony obliteration. And therefore, especially in cholesteatoma cases, we all know that sequential surgeries are necessary and do mostly not result in meaningful improvement of hearing, unfortunately. So I'd like to share a case study with you, a female, 53 years of age, bilateral COM, already several mastoidectomies, and regarding the right ear, cholesteatoma was treated and obliterated after the combined approach tympanoplasty in 2021. There was no stapes structure, superstructure, so there was a TORP, total ossicular replacement prosthesis, inserted. This is the otoscopic view after surgery, which is of course showing a nicely addressed cartilage in the membrane. You can see part of the malleus handle, and you can also see some redness in the tympanic membrane. This is the audiogram. You must trust me that rechts is right and links is left in Dutch, but you can also recognize the colors, of course, red and blue, like you're all used to. And it shows a mixed hearing loss, especially on the right side, and mainly conductive hearing loss on the left side. And this is my example for addressing this holistic approach to healthcare. And it is a very broad sentence. And of course, there is much to it. So I'm really happy that we have this Q&A session after all the presentations. So maybe we can have some more detailed discussion about it. But all the patients with COM undergoing successful middle ear surgery, they do indicate that their hearing has improved post-operatively. Also, their air-bone gap improves. Still, shortly, midterm, or maybe later after surgery, there might be ongoing hearing loss, especially in the cases with mixed hearing loss and asymmetrical bone conduction thresholds. These outcomes limit the quality of life. They have impact on communication skills. And an in-depth conversation to really uncover the additional needs of each individual patient is very important. So what would you suggest this patient? And of course, if you are here listening and you are an ENT surgeon, you might suggest, well, a total ossicular replacement prosthesis is very difficult. It might be tilted. You might need to do revision surgery, maybe have a longer or shorter prosthesis. You can look into the middle ear. It's a very common technique to do an ossiculoplasty again. That might be an option. And if you are an audiologist, perhaps, you might say, well, of course, the tympanic membrane looks a little bit red in the case of the female 53 years of age, but you can try conventional hearing aid. I mean, that's the best way to rehabilitate hearing loss. And yeah, if you're part of the Healthy Hearing Ears initiative, then you would say, well, did we consider bone conduction solutions already in this patient? And that's what I believe is the main important thing of the Healthy Hearing Ears meetings that we had so far, and that we believe that the hearing outcomes in chronic otitis media are often assessed too narrowly. And the clinical success is frequently defined by air bone gap closure alone, why we feel it should be more holistically reported, and be honest about the success rates, because these are often overreported in the literature. The residual sensory neural hearing losses may remain despite successful surgery, so you really need to address that part of hearing loss as well. And you need to in-depth question your patients about the functional hearing limitations, particularly in noise or in other specific conditions, and they're often underassessed. We can use and really advise to use quality of life instruments, patient reported outcome measurements, as they are currently not routinely monitored. These hearing assessments are often more episodically rather than continuously, and really at strict time points during the care pathway. And we believe that not having this continuously assessed at fixed time points may result in delayed identification of the suboptimal hearing. So therefore, in the paper we already have been talking about during this webinar, the expert opinion statement number 3 is listed here: conducting structured monitoring of hearing and hearing-related quality of life status in patients with COM allows timely adjustment of interventions based on a holistic approach to healthcare. So if we look into the literature again, you see that this study focused on the comparison of mental health and quality of life in chronic otitis media patients versus the hearing population. And it is a lot of text on the slide, but you can trust me if I say you that the study results indicated that the COM patients with mild or moderate hearing loss have poorer quality of life and higher psychological problems. So what we believe is, do not only or solely rely on the air bone gap closure as an outcome measure. We believe it's important to evaluate speech understanding and noise where possible, assess effective gain with hearing devices, and include patient-reported outcome measures for hearing-related quality of life. And this can be this health-related instrument that Faisal just showed. It can also be the COMOD or the OQA. There are many systems that you can use, and we do a recommendation in the paper that we mentioned earlier. Conduct assessments before and after interventions, especially hearing assessment, but also quality of life assessment in the context of your care pathway. And then last but not least, in the plan, do, check, act cycle, also monitor hearing longitudinally across the COM care pathway and see how it continues. So take back to work messages. The care of our COM patients should shift, like we already addressed, from safe ear first to safe and hearing ear parallel or simultaneously, because early bone conduction hearing prevents long-term hearing loss and improves quality of life. And this interdisciplinary collaboration between audiology, ENT, patient, and this holistic approach is essential in the care pathway, especially in COM patients. So we believe it's time for a new worldwide care pathway for COM. Diagnose, safe ear, direct hearing optimization, and then monitor and adjust. Because to end with this statement, the ear is not necessarily ready for surgery, but the brain is ready for hearing. And I thank you very much for your attention and look forward to the discussion section.
Thank you, Dr. Hull, for that wonderful presentation. That is a really great quote to summarize all of the 4 speakers. And I think from all the speakers, we could tell that having a safe ear is important, but having early access to hearing is equally important. We have some very good questions in the Q&A. If I can get all the speakers to turn on their camera, we can go through some of those questions together. So I see a question here from Jerome Evans. Do you feel the wait time is justified for those who have normal hearing in the non-impacted ear? Does the impact on quality of life of one normal hearing ear needs to be discussed? Maybe, Ivan, we can get you to share your perspective on having one normal hearing ear as well as one ear that is going through both COM and hearing rehabilitation.
Yeah, sure. For me, it's obvious that one ear is not enough. It is not sufficient, especially for these noisy environments or for the localization of sounds. Having one ear is not enough.
Any thoughts on your end, Hillary, for especially children that you see in your practice? Many of them have COM in just one side.
Yeah, absolutely. And this is probably the most common presentation is unilateral. And I think it really contributes to some of the misnomer about when is the appropriate time to treat. So I think your point is really well taken and would strongly agree with the premise behind your question. You know, as an anecdote, this patient who was 12 at the time, so a child, when we activated the bone conduction device, her response was, "Wow, I can't believe how hard my other ear has been working this whole time." I mean, that was immediate organic response from the patient. And I think it really mirrors what Ivan just said about how difficult it really is to operate with one ear. And, you know, we know that there's documented in the literature, evidence around persistent hearing loss, even if it's unilateral, and that it's really not benign, particularly in children. So, you know, the reduced speech perception and noise, increased listening effort, the cognitive load, all of this can lead to difficulties in academic performance, social engagement, which also can extend into our adult population. So I would persist that the watch and wait or the wait and see is really not the best approach, even if they are unilaterally impaired.
Thank you, Dr. Snap. We have another question here from Neil Sperling. What are the surgeon's opinions of simultaneous bone conduction implant at the time of mastoidectomy? And maybe we can get Dr. Mirtha Hall to comment on that.
Thank you. It's actually an excellent question. I think you're already trying to incorporate the message that we're spreading about simultaneous approach about the ear and the hearing. Although I do feel that if the patient is operated for the first time, especially in cholesteatoma cases where you might need some follow-up, we use MRI follow-up, for instance, so you really need to make sure that you can see everything in the MRI. Depending on whether it's unilateral or bilateral, how many ossicles are already damaged or not. I mean, what is the findings during surgery or in the pre-surgery workup, of course. I do believe that in most of my patients, I do not simultaneously implant a bone conduction hearing device at the first surgery. I do monitor after surgery what the hearing loss is, and I do manage the hearing loss with non-surgical bone conduction solutions quite soon after surgery. And therefore, if we know that they benefit from it and they get repeated surgeries, for instance, because cholesteatoma has become an urgent for surgery again because there was a residual or a hearing of residual cholesteatoma, then I do discuss this with the patient, whether he or she likes this bone conduction solution, and provided that we have noticed what the ossicular chain reconstruction did or did not do in the previous surgery, then I offer them the option to simultaneously operate a bone conduction implant on them. Although this is my preference to use a percutaneous implant for that reason, because you need to have follow-up MRI So that might, if the patient prefers a transcutaneous active device, to wait until the follow-up of the MRI scans for at least 5 years, in my opinion, before implanting a magnet there. That's what my approach would be.
Thank you, Dr. Hull. Any different approaches on your end, Dr. Zawawi, in your practice?
I think it's very similar. The two things I would add is that there is an option to do an implantable solution if the patient is a candidate for that, depending on their mastoid surgery. For example, if they end up with a canal wall down or a mastoid ball and what have you, and you feel it's safe for you to monitor the patient clinically without the need of recurrent imaging, then there is a solution that you can put an implant, an active transcutaneous implant in there. Thankfully, those are rare patients. That's not the usual for us. The other possibility that we don't really do regularly, which is the use of percutaneous implantation. And those are implants that we can have access to MRI because there is no magnet there. Unfortunately, those come with their own mixed bag of issues, the granulation, the hygiene, or what have you. So we've somewhat steered away from them recently. I think the message here is that let's give these patients hearing, whether it's implantable solution or non-implantable solution, they should have hearing.
Thank you, Dr. Zawawi. We have another question from an audiologist who works in public schools, and this might be a good question for you, Dr. Snap. So Catherine mentions that she's often the first specialist to talk to families of young children about pursuing otolaryngology or hearing follow-up, even if they've been seen by their primary care provider several times due to middle ear issues. Any advice on when to guide families to seek this medical and audiological treatment pathway, so to see a specialist?
Yeah, thank you. That's an excellent question. And I think your role in the schools is actually one of the most important early entry points for care for these kids. So my strongest guidance would be that as soon as there's evidence of chronic or persistent hearing loss, families should really be referred directly to ENT and audiology without waiting for repeated primary care cycles to play out. From a standards perspective, this really aligns with the Joint Commission expectations around timely identification and escalation of clinically significant findings, particularly when there's evidence that there's a functional impairment, right, a hearing loss that's impacting them in the school. And so I think when we think about the risk of communication and, performance in school, development, et cetera, the underlying principle is really that the deficit is, once it's identified and it's persistent, it should trigger an appropriate specialist referral rather than, prolonged observation in a non-specialty setting, for example.
Thank you, Dr. Snap. And even from your personal experience, I noticed in your presentation that it took over 10 years of struggling with COM before receiving your first audiogram. So if you were to go back into your shoes, going back to your journey, do you wish that someone would have guided you to see an audiologist or to receive a hearing access a bit sooner in that journey?
Yes, sure, of course. And before having audiograms, I remember that there were these tests with the forks and metal forks to put them in the head. And I had to say where the sound was going. But I didn't have any formal audiograms or a hearing test, and I wish I had them before. And I wish that I discovered or somebody told me about the bone conduction before. And I mentioned that I had this hope through all these surgeries on mastoidectomy to have a middle ear reconstruction. And I wish also that somebody told me since the beginning, maybe this is not the best approach in your case, because I was ready to go through that pathway as well, to have multiple middle ear reconstructions without knowing that maybe they are not successful the first time. Yeah, I wish I had known a lot of things sooner.
Thank you, Ivan.
Yeah, I would also comment on the case that I presented, the child who it was 12 years before they got into a permanent hearing solution, but they also never had a soft band solution, even though they were identified before a year of age with a chronic middle ear issue. And had we been able to access that child at that time point and introduce bone conduction solutions and hearing solutions at that first entry point, it would have actually enabled us. It's a great example of enabling us to get into a surgical solution sooner. One of the issues that came forward with this child, and we've seen many times in our practice, is a reticence for children and parents to move forward with an intervention, a permanent intervention, because they've had so many recurring surgeries that have left them disappointed because the hearing has actually not changed. And so there is an experience that is associated with that maybe prevents them from really trusting that this other type of surgical intervention or hearing intervention will actually benefit them. So I think it really, pushes to the point of how important that early entry point with a non-surgical solution can really set people up for success in the long term.
Thank you for sharing, Dr. Snap. We have another question from Dr. Wasano from Tokai University in Japan. And this may be a good question for Dr. Hull and Dr. Zawawi. Do you have any experience with osseous implantation in patients who have undergone post-operative radiotherapy following surgery for malignant tumors of external auditory canal? I am concerned that osseointegration into the bone might be delayed. Are there any particular precautions or considerations I should be aware of? Any comments on your end, Dr. Hull?
Yeah, I guess if I understood your question right, because I was looking in the chat to read with you, but I didn't see it yet. But it was about the osseointegration after radiotherapy. Is that the question?
Yes, that's correct.
Yeah.
Following surgery for tumors.
Yeah, so that's a very important remark, and also important to realize that we believe that since the percutaneous implants got wider diameter implants with the coating, the stability and the risk in failure decreased enormously. In the patients that we have been testing with and without radiotherapy, the difference with these wide diameter implants was not significant or not showing in the results we had, although we must be honest that there are no large databases like the series we also published with thousands of implants, because not all in these cases there was radiotherapy addressed. So if you would really like to have a safe answer for it, then I believe it is a very individual based choice. And should the patient wish for a bone conduction device, the options are, especially in the cases that they need repeated MRI scanning, and therefore a magnet might not be a solution for these patients, a percutaneous implant can be an option. And you could also decide to stage it in these cases, to put a implant under the skin first, leave it there for 3 months, and then also in the outpatient clinic in local anesthesia, put the abutment on the implant, and then it has time to really osseointegrate there.
Thank you, Dr. Hull.
So if I wanted to add a couple of things, I agree with Dr. Hall. I think if the patient is a candidate for example, an osseous or any active transcutaneous bone conduction, meaning that they don't need the MRI anymore. For osseous per se, or even other implantable solutions, the bone osseointegration, I don't think you'll face a lot of problems with it because of what Dr. Hall has mentioned. But what you should be concerned with is the skin. So you have to be careful planning your incisions, making sure really staying away from the device, not adopting some of those incisions that go over the device, as wound healing and wound dehiscence is high in these patients, because you're probably going to place the device somewhere close to where the irradiation has taken place, so the skin has been irradiated. So just be mindful of that. If it's possible to plan the incision away from the area of radiation, that would be great. If not, just be careful. Plan the incision to be far away from the implant to avoid any tension over the suture line, and maybe delay the switch on of the implant rather than we usually switch on, activate the implant at 3 weeks post-operatively. But in these cases, I might wait for 6 weeks just to make sure the healing has completed.
Yeah, excellent to add that, Dr. Fazai-Sawawi, because it's really an important issue you mention here. These patients do have lots of problems, more often problems than other patients with the healing of the skin. And I wanted to add that maybe if it's available in your country, the oxygen, hyperbaric oxygen therapy is sometimes helpful in this matter to have this pre-surgery, during and after surgery treatment to increase the skin healthiness.
Thank you, Dr. Zawawi. Thank you, Dr. Hull. I am also cognizant that we are at time. There are still some questions that we were not able to answer, but please get in touch with your Cochlear representative if you have any further questions, and we can be sure that these professionals receive them and we're able to put together some answers for you guys. I want to thank all of our speakers for their time and their expert guidance through this very complicated topic that generates, of course, a lot of really good discussion. Thank you, everybody, and thank you, everyone, for taking the precious time out of your day to tune into today's webinar. We will have another one of these in a couple months' time, so be sure to be on the lookout. We will also send a thank you email, so if you have any other follow-up questions, be sure to send us a response back. Thank you, everybody, so much for your time. Have a wonderful rest of your day.